I would like to share a case of a 43-year-old male with no past medical history who presented to Santa Barbara Cottage Hospital ED with complaints of intractable nausea, hiccups, and vomiting for 3 weeks after treatment for prostatitis. He had associated 20-pound weight loss and urinary retention. Vital signs showed borderline low blood pressure, but otherwise all other values were within normal limits. His physical exam was benign. Of note, he had multiple ED visits in the month prior and was given trials of Zofran, baclofen, lorazepam, and thorazine without any relief. With his inability to tolerate any PO intake and extreme weight loss, patient was admitted for further workup. His laboratory values showed an unremarkable CBC and a CMP only significant for low potassium. A CRP and a procalcitonin were negative. Further workup for metabolic and toxic etiologies did not reveal any abnormality. CT, chest, abdomen, and pelvis were normal. In the first couple days of his admission, he underwent an upper endoscopy that did not find any explanation for his symptoms. Patient then had a lumbar puncture which showed 63 WBCs with 90% lymphocytes, 516 RBCs, glucose of 52, and protein of 44, suggesting an inflammatory or infectious process. However, CSF and serum cultures and infectious serologies were all negative. He then underwent an MRI brain and spine that showed multifocal white matter edema with restricted diffusion and enhancement in bitemporal lobes, right pyramidline, right caudate nucleus, posterior medulla, as well as inflammatory changes in the level of the conus. With the help of neurology, workup expanded to include autoimmune, vasculitic, and encephalitis panels, all of which returned negative except for patient's NMO aquaporin 4 IgG antibodies that were detected in the CSF, despite it being negative in his serum. This led the patient to be diagnosed with neuromyelitis optica with areopostrema syndrome. He was treated with plasmapheresis for 5 doses and symptomatically managed for hiccups with Depakote, with resolution of his symptoms prior to discharge. Patient was asked to schedule outpatient neurology appointment to initiate immunosuppressive therapy, but his lack of insurance led patient to be lost to follow-up until he was readmitted 2 months later. This time, he complained of right eye vision loss over 2 weeks and bilateral leg paresthesias. Repeat brain MRI and spine confirmed worsening disease. He was given 1 gram Zolumedrol on the day of admission and plasmapheresis for 7 days. He continued to experience paresthesias throughout his stay with slight improvement in his vision. He was discharged as his symptoms stabilized in anticipation of starting incluzumab or rituximab in the near future, depending on insurance coverage. Unfortunately, 1 week later, patient returned with progressive tingling and numbness of legs, leading to inability to ambulate for 2 days. Repeat NMO IgG antibody by cell-mediated assay titer, obtained as a marker for current disease state, returned positive at 1 to 100,000. He received Zolumedrol 1 gram for 5 days and plasmapheresis for 3 days, with subsequent improvement in his neurologic exam. Due to the severity and rapid progression, patient was started on rituximab 1 gram at discharge with repeat infusion 14 days later and again at 6 months. At his 6-month follow-up, patient did not have new symptoms and had 50% improvement in vision, persistent allodynia of his lower extremities, but normal strength and balance. Neuromyelitis optica is a rare autoimmune disorder known to attack the optic nerve and or spinal cord. However, it has been known to present with rare abnormal features and be classified under neuromyelitis optica spectrum disorder or NMOSD depending if diagnostic criteria can be met. If the patient has one of the 6 core clinical characteristics, including optic neuritis, acute myelitis, areopostrema syndrome, which includes an episode of otherwise unexplained hiccups or nausea and vomiting, acute brainstem syndrome, symptomatic narcolepsy or symptomatic diencephalic syndrome, symptomatic cerebral syndrome, and also be positive for antibodies against aquaporin 4 can be diagnosed with NMOSD. In summary, intractable nausea and vomiting are nonspecific symptoms that are usually associated with infectious or structural etiologies, and usually non-appreciated as a possible initial sign of NMOSD. In unexplained intractable nausea and vomiting, NMO should be considered. There is a growing frequency of reports of NMO with nausea, vomiting, and hiccups as initial presentations. A study done at Mayo Clinic reported a 12% prevalence rate of nausea and vomiting as the initial symptom of anti-aquaporin 4 positive NMOSD. This case demonstrates serious physical manifestations may develop later in the course, and high suspicion is needed for early diagnosis and initiation of immunosuppressive therapy to decrease further attacks, reduce morbidity, and provide symptomatic relief. Key points to take away are as follows. Autoantibodies targeting AQP4 water channels are sensitive and specific biomarker for NMOSD. Next, to highlight the unusual presentation of NMO, which should be included as a differential diagnosis for unexplained intractable nausea, vomiting, and hiccup. Lastly, for acute attack or relapse, 3 to 5 days of 1 gram methylprednisolone daily. For those who do not respond clinically or it cannot be safely given, plasmapheresis can also be effective. To prevent further attacks, using immunosuppressive therapy such as rituximab or azathioprine for prophylaxis.